Thanks. So my name is George. I'm a postdoc in the Yeomans lab, but like my other collaborators here listed, both Manish and Omer, we're all also clinicians at MGH, and this talk will get into the intersection between those two sort of events. And so the title is Organoid Oncology, Making Sense of Sensitivity. And so that brings us to the beginning where we're talking about stomach cancer. It's the KI. We are trying to treat cancer, and that's some of the sort of tenets and goals that we try to ascribe to. And so, unfortunately, there are about 26,000 new cases of stomach cancer diagnosed each year in the United States. And on the left is a histologic image, which is what a pathologist looks at when they look at tissues. And I and Omer are both pathologists. And that's actually a histologic image of normal stomach. And a known risk factor for getting stomach cancer is infection with a bacterium called H. pylori. But there are rarely hereditary causes that can induce stomach cancer. And once you get diagnosed with stomach cancer, often the standard of care involves chemotherapy. And unfortunately, those chemotherapy regimens are not universally standard, and responses can be variable. And so we in the lab are thinking, can we improve this using organoid testing and organoid technology? But what is organoids? What are organoids, and what is organoid technology? And so what we can do is we can dissociate the crypts, so the cells that make up the tissue as shown in the previous image, dissociate them from the underlying tissue and grow them in the lab. And this is an image of those dissociated cells in the crypt-like architecture that they retain. And what we do is we put them in a jello-like material, as shown on the right, and place it in the bottom of a culture well. So we're able to grow it in an incubator and grow it in the lab and study it. And we're also able to overlay it with different media conditions to study things like chemotherapy and response to different stimuli. And so I just want to warn people that maybe sort of like the previous talk, the next image is a little bit graphic, but this one is from the patient that actually the image and the organoids were derived from. And so as you can see on the left, this is actually an endoscopic image of the tumor that the patient had. So this was an endoscope, is like a camera that you advance down some of these the esophagus into their stomach. So this is a picture of their stomach, and it's pretty obvious that there's a large misshapen fungating mass right there in the center, and it's got irregular borders, a lot of funny coloration, and that's in comparison to the smooth, regular kind of aspect of the mucosa on the outer edges. And so what I did, I went with Manish to do this case, and what we were able to do is get biopsies from both the tumor areas seen there, as well as the normal areas. And I brought them back to MIT, and we were able to grow them here as organoids. So on the top is a representative image of tumor organoids, and on the bottom is a representative image of the normal organoids as we grow them in the lab. And so one thing that we knew about this tumor and was specific to this patient was they had a lack of this gene called ATM. And so what we're able to do is study that in the lab by staining for it using a fluorescent staining. And so the presence of that protein is labeled in red. So the normal organoids retain that color, retain that protein as seen on the left, but the tumor actually lacks that protein. And as you can see, there's no red staining. And this was part of the hereditary basis of this patient's specific cancer. And because we identified that and we knew that, we were able to identify specific sensitivities for the tumor based on this knowledge. And so on the left is a line graph showing organoid viability on the y-axis, which is how much the organoids survive. And on the x-axis, as you go left to right, an increasing concentration of a chemotherapy. And the chemotherapy used there in chemotherapy A is a standard chemotherapy used for treating gastric cancer. And so as you can see, the tumor cells actually are a little bit more sensitive in that they start dying earlier when exposed to an increasing concentration of chemotherapy in comparison to the normal. And that's what an oncologist wants to happen. You start killing off the tumor cells before you kill off the normal cells. But because we knew something about the tumor, that the tumor was ATM deficient, we can use a different chemotherapy, chemotherapy B, which shows a huge range where the tumor cells are very sensitive to this particular chemotherapy in comparison to normal. So you can get away with much less dosage of chemo, and you really very limitedly hurt the normal cells. And that's overall the goal that we had with this project. And so this final image, which is slowly coming, is the image that was chosen for the award, and is actually a picture of the normal organoid grown. Okay, and that's the picture of the normal organoid. And this is one of the images that I was just struck by, sort of the appearance that it had and sort of the three-dimensionality of it. And that's why I submitted it. And so I want to thank Omer, Manish, the entire UMass lab, and of course the patients that consent to participate in research, as well as Erica and the KI Image Awards, and then all of the cores and at the KI, which made this happen.